Good morning, all. Myself, Dr. Anupriya, Assistant Professor of OG SLIMS. The topic for discussion today is cervical intraepithelial neoplasia. We'll look into the topic version. First of all, cervical intraepithelial neoplasia, otherwise called as CIN, it is a precancerous benign lesion of the cervix. It usually occurs 10 to 15 years earlier to the cervical carcinoma. Hence, effective screening of CAN and prompt intervention prevents the incidence of cervical carcinoma. Moving on to the definition of cervical intraepithelial neoplasia, CIN refers to it is a histopathological description in which a part or full thickness of stratified squamous epithelium, that is transformation zone, is replaced by cells showing varying degrees of dysplasia with an intact basement membrane. This intact basement membrane along with dysplasia is the characteristic feature of CIN. So moving on to the transformation zone, squamocolumnar junction is defined as the border between stratified squamous epithelium and the endocervical columnar epithelium. Morphogenetically, there are two squamocolumnar junctions. Original squamocolumnar junction is the one which is seen at birth. Subsequently, with puberty, sexual activity, and pregnancy, there is ectopy of the previous original squamocolumnar junction, that is endocervical epithelium, which undergoes squamous metaplasia, resulting in the formation of new squamocolumnar junction. The region between the original squamocolumnar junction and the new squamocolumnar junction is called as the transformation zone. So all lesions of the precancerous cervical lesions as well as cancer cervix will originate from this transformation zone region only. So this picture is showing the original squamocolumnar junction, which is lying outside. So at puberty, this original squamocolumnar junction will be ectopic. So the new squamocolumnar junction, the region between the original squamocolumnar junction and the new squamocolumnar junction is called as the transformation zone. In this picture, it is depicted in yellowish in color. So this is the region where all precancerous lesions and cancerous lesion of the cervix will originate. Moving on to the terminology. Terminology is devised by WHO, Richard, and modified Bethesda system of classification. In WHO, it will correspond to mild degree of dysplasia, that will correspond to CIN1, that will correspond to LSIL, which is nothing but low-grade squamous intraepithelial neoplasia in case of Bethesda system of classification. So the dysplasia will be limited to basal 1/3 region of the cervical epithelium. In case of moderate dysplasia, that will correspond to CIN2, that will correspond to HSIL, which is nothing but high-grade squamous intraepithelial neoplasia in case of Bethesda system of classification. So here, the dysplasia will be limited to the basal 2/3 layers of the cervical epithelium. Moving on to the third classification, which is nothing but severe degree of dysplasia, will correspond to CIN3, also called as HSIL, high-grade squamous intraepithelial neoplasia in case of Bethesda system of classification. Here, whole thickness of the cervical epithelium will be dysplastic, but the only difference is there will be intact basement membrane in case of all types of CIN lesions. In case of carcinoma in situ, that will correspond to CIN3 in correspondence to the Richard classification. According to Bethesda, it is again HSIL, which is high-grade intraepithelial neoplasia. The only difference between all the three types of CIN lesions and this carcinoma in situ is the basement membrane is not intact in case of carcinoma in situ. Basement membrane will be breached in case of carcinoma in situ. So this is the picture which is showing different degrees of dysplasia. The left side one is the normal cells seen in cervical epithelium. While taking pap smear, only superficial cells will be seen in case of pap smear. When it is CIN1, it is intermediate cells will be seen in pap smear. In case of CIN2, parabasal cells will be seen in pap smear. And in case of CIN3, even basal cells will be predominantly involved. Normal cells will have normal nuclear size, normal pleomorphism, normal nuclear anisokaryosis, nuclear hyperchromasia will be normal and less number of mitotic figures. Basal cells will be lesser in case of normal pap smear, in case of normal cervical cytology. And this grade increases from low-grade squamous intraepithelial neoplasia to high-grade intraepithelial neoplasia. As the grade of the CAN increases, all the nuclear size, pleomorphism, anisopoikilocytosis, hyperchromasia, and more number of mitotic figures and more number of basal cells, that too disorderly arranged basal cells will be commonly seen. Moving on to the course of CIN, age group involved in case of CIN 1 is 25 to 30 years. In case of CIN 2 is 30 to 35 years. In case of CIN 3, it is 40 to 45 years. The percentage of regression of CIN 1 lesion is 60%, whereas in case of CIN 2, it is 40%, whereas in case of CIN 3, it is 30%. And persistence of lesion even after treatment is 30% in case of CIN 1, 35% in case of CIN 2, 50% in case of CIN 3. And progression to next stage is 10% in case of CIN 1. And in case of CIN 2, it is 20%. And progression from CIN 3 to progression to invasive carcinoma, invasion is 20%. But in case of CIN 1, it is less than 1% invasion to invasive carcinoma will be there. But in case of CIN 2, it is only 4% invasion to invasive carcinoma. So CIN 3 will have higher percentage of invasive carcinoma. Risk of developing invasive carcinoma, the CIN 3 has higher risk. Moving to the etiopathogenesis. The main culprit or the main causative agent in case of carcinoma, precancerous lesions of cervix, also the carcinoma cervix is human papilloma virus, which is nothing but a DNA virus. Transmission modality is via sexual contact. HPV infection is not necessarily to cause precancerous and cancerous lesion of cervix, but not sufficient alone. Most infections are transient in young women. When treated accurately, it will resolve spontaneously. Major influencing factor will depend upon subtype of HPV and persistence of infection. Low risk human papilloma virus or serotype 6 and 11. Only these two will cause low grade lesion, that is CIN 1 and genital warts. High risk HPV types includes serotype 16, 18, 31, 33, 45, 52 and 58. These all type of serotypes will cause high grade lesions. For example, CIN 2 and CIN 3, persistence and progression to cervical cancer. So 6 and 11 are low risk serotypes. All others are high risk serotypes of human papilloma virus. Along with this human papilloma virus infection, there are some cofactors for development of precancerous lesions and cancerous lesions of cervix. Those are HIV infection, immunosuppressive therapy, as in case when given in transplant recipients, and systemic lupus erythematosus patients, old age people, cigarette smokers, synergistic effect with human papilloma virus. 15-fold, there's 66-fold increased risk of developing the precancerous and cancerous lesions of cervix in cigarette smokers. Correlation with cumulative exposure is there. And oral contraceptive pills. Long-term use in HPV positive women will return to baseline risk after 10 years of discontinuation of oral contraceptive pills. Herpes simplex viral infection and chlamydial infection will also predispose to the development of pre-invasive and invasive lesions of cervix. Multiple sexual partners, genetic susceptibility due to certain types of HLAs. So how can you prevent this precancerous lesions and cancerous lesions of cervix caused by human papilloma virus? There are some vaccines which has been invented for prevention of human papilloma virus infection. There are different types of vaccine. The most commonly used one, these three are the most commonly used vaccines. First one is Cervarix, which is a bivalent vaccine, which is manufactured by GlaxoSmithKline. It is effective against HPV serotype 16 and 18. Second one is Gardasil, which is a quadrivalent vaccine. As the name suggests, it is effective against 4 serotypes of HPVs. Serotype 6, 11, 16 and 18. Third one is nanovalent vaccine, which is called as Gardasil 9, which is manufactured by Merck and Co. It is an FDA approved. FDA had approved this nanovalent Gardasil 9 vaccine on 14th of December 2014, and it is effective against HPV serotypes 6, 11, 16, 18, 31, 33, 45, 52, and 58. So it is effective against all 6 serotypes of human papilloma virus. So its efficacy is also more when compared to other 2 types of vaccines. So moving on to the different dosage of different vaccines. Manufacturer is GlaxoSmithKline in case of Cervarix. Gardasil, it is Gardasil and Gardasil 9 is by Merck and Co. Composition is 20 microgram of HPV 16 and 20 microgram of HPV 18 for Cervarix. And in case of Gardasil, it is 20, 40, 40, 20 microgram. Respectively, HPV 6, 11, 16, and 18. And in case of Gardasil 9, it is all 9 types of serotypes. It is effective against all 9 types of serotypes. So the adjuvant used is aluminum hydroxide and decasyl monophosphoryl lipid A. And adjuvant used in case of Gardasil is amorphous aluminum hydroxyphosphate for both Gardasil and Gardasil 9. Preservative, no preservatives used in any of the vaccines. Dosing schedule will vary between Cervarix and Gardasil. For both Gardasil and Gardasil 9, it is 0, 2, and 6 months. And for Cervarix, it is 0, 1, and 6 months. So 3 doses will be given for HPV vaccination. HPV vaccination guidelines, routine vaccination at 11 or 12 years can be initiated as early as 9 years of age also. If not vaccinated or not completed 3 doses, this vaccination can be recommended from 13 years till 26 years of age. For immunocompromised women also, this vaccination is recommended till 26 years of age. All 3 types of vaccines can be given in females. So this vaccination will also prevent against vaginal intraepithelial neoplasia, anal cancers, vulval intraepithelial neoplasia, in addition to prevention of cervical cancers and pre-invasive cervical lesions. So screening recommendations will vary. A regular screening interval of every 5 to 10 years when cytological screening is combined with HPV DNA co-testing. And in case of only cytological screening is done, it is done every 3 years once. Screening even just twice in a lifetime is beneficial for HPV screening. So screening methods, there are different screening modalities for cervical cancer. First modality is cytological examination. Second one is HPV testing. And third one is visual inspection of the cervix. Cytological examination again can be done with either pap smear or with liquid-based cytology. HPV DNA testing can also be done. Visual inspection of the cervix can be done with either acetic acid or with acetic acid and magnification is the second one. And the last one is with local iodine, that is called as villi. With acetic acid, it is called as via. So this picture is showing the conventional pap smear. The right side picture is showing the OS spatula and cytobrush, which is used for taking the pap smear. Prerequisites for taking pap smear should be done in the post-menstrual phase of the menstrual cycle. Abstinence for 48 hours or more is essential. No vaginal douching or intravaginal creams or contraceptive cream should be used for prior 24 to 48 hours before taking pap smear. Any cervicitis or vaginitis must be treated prior to taking pap smear. So the sampling for pap smear can be taken with either OS spatula or with endocervical brush. Anything can be used for taking pap smear. The next modality for screening purposes, liquid-based cytology. This uses cervix brush combi. This picture is showing the cervix brush combi. Cytology collected using a cytobrush. Head of the brush is vigorously shaked or broken off into the liquid medium and transferred. Smear of this liquid medium, smear of monolayer of cells will be prepared from this liquid medium. So advantage of this thing is there is no drying artifact which will be seen in case of pap smear. Blood, mucus, discharge, and other cells does not interfere with the interpretation of the cytological report. 80 to 90% of cells transferred to liquid medium when compared to only 10 to 20% in case of pap smear. So here there will be more number of cells transferred to the liquid medium for study. So this is one of the advantage of using liquid-based cytology rather than conventional pap smear. So moving on to the Bethesda system for reporting of cervical cytology. Imagine we have taken pap smear and we have to interpret the findings of the pap smear. So for this, Bethesda has invented a system for reporting the cytology. So this includes epithelial cell abnormalities into 2 categories. One is epithelial cell abnormalities and another one is glandular cell abnormalities. So epithelial cell abnormalities includes the terminologies in epithelial cell abnormalities includes NILM, which is nothing but negative for intraepithelial lesion or malignancy. There will be no abnormal cells seen on the pap smear. So that is called as NILM. And then the second category is ASCUS, ascus, which is nothing but atypical squamous cells of undetermined significance. Another thing is ASCH, which is nothing but atypical squamous cells, but we cannot include high-grade squamous intraepithelial lesion. Then another one is LSIL, which is nothing but low-grade squamous intraepithelial neoplasia. And another one is high HSIL, which is nothing but high-grade squamous intraepithelial neoplasia. And carcinoma, per se carcinoma, that is squamous cell carcinoma of the ectocervix. Then moving on to the glandular cell abnormalities, mostly glandular cells will be seen in the endocervix. So atypical glandular cells, which is nothing but AGC, specifically endocervical, endometrial, or NOS, which is nothing but not otherwise significant. And another one is AGCFN, atypical glandular cells favor neoplastic. And another one is adenocarcinoma in situ, that is endocervical adenocarcinoma in situ. Endometrial cells in a woman for more than 40 years of age, adenocarcinoma, and others. These are the terminologies which will be given in case of reporting the pap smear or cervical cytology. So the next modality for screening of the cervical pre-invasive and invasive lesions of the cervix is the colposcopy. Colposcopy is an instrument which was invented by a physician called Hans Hinselmann. So this instrument will be used to magnify and to visualize the cervix, vagina, and vulva. And if any abnormal areas has been detected, we can able to take biopsy from that abnormal area with the help of this colposcopic screening. So colposcopic warning signs. So these are some of the warning signs that signifies that that involved area is abnormal. We have to take biopsy from that tissue biopsy from the involved abnormal area. First one is degenerative friable epithelium with contact bleeding on touch. Another one is irregular surface contour when occurring in a high-grade colposcopic abnormality. Then surface ulceration or erosion when occurring in a high-grade colposcopic abnormality. Atypical blood vessels. Blood vessels will be coarse, varicose, irregular caliber, non-dichotomous branching, long unbranched pores will be there. So these are the atypical blood vessel changes. Abnormal vascular pattern includes mosaicism, punctations, umbilications, etc. Large lesions occupying 3 or more quadrants with RCI more than 6. High-grade colposcopic lesions extending into the cervical canal 5 millimeter or beyond into the cervical canal. So all these are the warning signs which can be seen in case of colposcopic examination of the cervix. So there is some scoring system for reporting of this colposcopic examination findings. Two set scoring system are there. One is sweet score and another one is Reed's index. Sweet score will have 5 parameters and the least score, lower score is 0 and the maximum score that can be given is 10. So the parameters that are included under sweet score is uptake of acetic acid, margins and surface, vessels, lesion size, iodine staining. So uptake of acetic acid will be 0 or transparent. That score will come 0. Shady or milky 1. For score 2, it is distinct or streak-like staining will be there. Margins and surface, it will be diffuse margins that will come under 0. Sharp, irregular, jagged geographical satellites that will come under score 1. Score 2 signifies sharp and even difference in surface levels such as cutting. Vessels will be fine and regular, that will come under score 0. When vessels are absent, it will come under score 1. When vessels are coarse or atypical, it will come under score 2. Lesion size will be less than 5 millimeter. Lesion size will be between 5 to 15 millimeter or spanning for 2 quadrants. Then lesion size will be more than 15 millimeter or spanning 3 to 4 quadrants or endocervically undefined. Iodine staining will take up the mahogany brown color, then it will come under score 0. When cervix is when only faintly or patchy yellowish staining is there, that will come under score 1. When there is distinct yellowish staining, that will come under score 2. So this is sweet score. Moving on to the Reed's index. In Reed's index, there are 4 parameters that can be studied. One is margin and surface of that abnormal area, color of aceto-white area, vessels, iodine staining. Again, the least score is 0 and the maximum score here is 8. So score between 0 to 2 will come under low-grade lesion. Score between 3 to 5 will have overlap findings. Score between 6 to 8 is called as high-grade lesion. So colposcopic findings will be interpreted with the help of the sweet score and Reed's index. So once screening has been done, screening with cytology has been done. So patient was found to be having ascus, which is nothing but atypical squamous cells of undetermined significance. In a woman who's aged more than or equal to 30 years of age, the treatment plan will vary depending upon the type of lesion and depending upon the age group of the patient. So when the the interpretation has come as ascus, we have to do HPV testing. If HPV testing is negative, we have to return back to routine 5-yearly screening with HPV co-testing along with cytology. If HPV testing has come as positive, you have to do colposcopy with or without biopsy. If colposcopy and biopsy comes as normal, then co-testing with HPV test at first year after this has to be done. If colposcopy shows abnormal area, you have to follow the FOXY CAN management that will be seen in later on slides. Or else cytology at 1 year has to be done. Cytology, if it is negative, you have to return back to routine screening. If cytology again shows a ascus or LSIL, low grade squamous intraepithelial neoplasia, again colposcopy with or without biopsy has to be done. If it is normal, cytology at 1 year you have to do. If it is abnormal, we have to follow the CAN management. If it is ASC, high-grade squamous intraepithelial neoplasia, you have to follow screening along according to GCPR guidelines. So screening with cytology, management of LSIL in women aged more than or equal to 30 years of age. Again, HPV testing has to be done. If it comes as positive, again colposcopy with biopsy has to be done. And if it comes as positive, we have to manage according to the GCPR guidelines. If HPV testing has come as negative, co-testing should be done at 1 year. Cytology is normal and HPV DNA testing is also negative. Co-testing done at 3 years. Cytology normal and HPV again it is negative, means you have to return to 5-yearly routine screening. If co-testing at 1 year is showing cytology more than or equal to ascus or HPV positive is there, we have to do colposcopy directed biopsy and we have to follow the management according to FOXY GCPR guidelines. Or else directly we can go in for colposcopy biopsy rather than doing HPV DNA testing. If patient is not non-compliant, if the patient is not willing to follow, if the patient is not able to come for regular follow-up, we have to see and treat the patient at that point of time, at the point of diagnosis itself. So next category, management of ascus or LSIL in a woman aged less than 30 years of age. We have to repeat cytology annually twice. 2 times annually we have to do. If it comes as negative for malignancy or intraepithelial lesion, we have to repeat cytology at 3 years. And if it comes as negative, we have to return to routine screening by age specific modality. If that repeat cytology is also more than or equal to atypical squamous cells of undetermined significance, we have to again do colposcopy directed biopsy. If it comes as normal, we have to repeat cytology at 1 year. If it comes as abnormal, we have to treat according to the GCPR guidelines. So management of ASCH, atypical squamous cells of high-grade or high-grade squamous intraepithelial neoplasia in women aged more than 30 years. Colposcopy with cervical biopsy or endocervical assessment has to be done in case of high-grade squamous intraepithelial neoplasia. Adequate anterior transformation zone is seen, and if it is diagnosed as less than or equal to CAN1, we can go for ablative procedure, and we have to follow up the patient with co-testing, that is HPV DNA testing plus cytology, or co-testing at first year and manage according to GCPR guidelines. If it comes as CAN2 or CAN3, then excisional procedures should also be considered. Large loop excision of the transformation zone or ablative procedures of the transformation zone, that is see and treat policy should have to be followed. If colposcopy with cervical biopsy and endocervical assessment is inadequate, for in case transformation zone is not completely seen, you have to go in for diagnostic excisional procedure, that is called as conization, and you have to treat according to GCPR guidelines. Eligibility for this thing, see and treat excisional procedure. These are some of the eligibility criteria for see and treat excisional procedures. First one is abnormal lesion should be entirely visible. That should be limited only to the cervix. That should not extend to the endocervix. Entire lesion should be located on the ectocervix without any vaginal and or endocervical extension. There is no suspicion of invasive cancer, and patient should be non-pregnant for see and treat excisional procedures. So moving on to the scenario where women with CAN presents in pregnancy. CAN in pregnancy, we have to review colposcopy report for adequacy. If it is low-grade lesion, followed with colposcopy at 6 weeks postpartum. After at 6 weeks postpartum, we have to review the patient with colposcopy. If it is high-grade lesion on colposcopy, repeat colposcopy at every trimester to rule out the development of invasive carcinoma, invasive disease, and review and treat it again 6 weeks postpartum. If patient comes presents with invasive cancer, offer treatment according to the period of gestation with which the patient is presenting. So moving on to the management of women with CAN1 on histology. CAN1 on histology, tissue diagnosis. Check preceding report of the patient. That is HPV report, cytology report, VIA report of the patient. Preceding HPV positive or ascus, LSAL or VIA positive. We have to perform co-test again, HPV testing, cytology testing, VIA testing at 1 year and 2 years. If the repeat test is negative, return to routine screening. If any time this HPV, cytology and VIA is positive, we have to directly go for colposcopy guided biopsy. And also in case it is ASCH or high-grade intraepithelial neoplasia, again co-testing has to be done. And if at any point of time, if it comes as positive, we have to go in for colposcopy directed biopsy. And again, we have to repeat co-testing. And in case of high-grade squamous intraepithelial neoplasia, it is better to go in for excisional procedures like LEAP excisional procedure. Assess adequacy of excision and you have to follow up the patient. Important thing after performing both ablative and excisional procedure is the follow-up period that you have to follow up the patient. Even during the follow-up period, SIN1 is persisting for 2 years means you have to go in for excisional procedure. Eligibility for ablative procedure includes lesion should be entirely visible and occupy not more than 2 quadrants of the cervix. Entire lesion should be located on ectocervix without any vaginal and or endocervical extension. Lesion can be adequately covered by largest cryotherapy probe available. There is no suspicion of invasive cancer. These are the eligibility criteria for performing the ablative procedures. Moving on to the management of women who is desirous of pregnancy with CAN1 on histology. So check preceding cytology report as in case of CAN1 who is not desirous of pregnancy. If it comes as ascus or LSAL, repeat cytology at 1 year. Cytology, if it is negative, routine screening, return back to routine screening. Or if any of the time cytology comes as positive, or if it is more than or equal to ascus, you have to do colposcopy directed biopsy and follow the management according to GCPR guidelines. If it comes as ASCH or high-grade squamous intraepithelial neoplasia, repeat cytology and colposcopy at 6-monthly interval. If it is suggestive of invasive disease, manage according to the standard of care. If it is not suggestive of invasive disease, repeat cytology and colposcopy at 1 year. If it comes as ASCH, HSIL or high-grade lesion and colposcopy persisting for 1 year, you should go in for diagnostic excisional procedure, that is re-and-treat policy. If it comes as ascus or LSIL, you have to follow the management according to GCPR guidelines. Moving on to the next scenario, management of women with CAN2 and CAN3 on histology, review colposcopy report. If it is adequate, consider performing LEAP or ablative procedure. Follow with the HPV co-testing cytology at 6 months, 1 year and 2 years. If the test is negative, return to routine screening. If the colposcopy report is inadequate, recurrent CAN is there, we have to perform conization. If cone margins are negative, we have to follow up with cone testing. If cone margins are also positive, repeat cone biopsy or considered hysterectomy. If repeat cone biopsy is not feasible, as in cases of postmenopausal age group, because in case of postmenopausal age group, cervix will already be atrophic. So repeat cone biopsy will not be feasible in these patients. Or patient non-compliant for follow-up, we have to consider hysterectomy, performing hysterectomy. those patients having margins positive. Repeat core test with HPV cytology at 6 months, 1 year, and 2 years. If it comes as positive, again consider repeat cone biopsy or hysterectomy according to subjective variation. Or if it comes as negative, return back to routine screening at any point in time. Management of women with CAN2 and CAN3 on histology who is desirous of pregnancy. You have to repeat cytology and colposcopy at 6 months. Lesion, if it still persists, repeat cytology at 1 year. If it still persists at the end of 6 months, you have to repeat at the end of 1 year. Cytology negative or else it is improving or normal colposcopy, repeat core testing cytology after 1 year. Normal reports, we have to follow the patient with again core testing or cytology at 3 years of at 3 years and during the follow period. When it comes as CAN2, triage with P16, Ki67. These are all tumor markers. If it is negative, we have to go in for normal routine screening. If it comes as positive, we have to perform colposcopy. If it is adequate, again cytology and colposcopy at 6 months and 1 year follow-up should have to be done. If it is inadequate colposcopy, consider doing excisional procedures. And in case of CAN3 with inadequate colposcopy, also consider excisional procedure in any case. If it comes as high-grade cytology or colposcopy worsens at the end of 1 year, consider doing excisional procedure or ablative procedure if eligibility criteria for ablative procedure is fulfilled. So if any abnormal report has come, first consider doing colposcopy directed biopsy. If during the follow-up period, if it is normal, return back to routine 5-yearly screening at any point in time. So this completes the management of the CAN lesions. The guidelines for CAN lesions, GCPR guidelines. Moving on to the ablative procedures and excisional procedures. The ablative procedures, the eligibility criteria for ablative procedure includes persistent CAN1 for 2 years or more, endocervical curettage negative or CAN1, CAN2 and CAN3 if colposcopy is adequate, if transformation zone is clearly visualized, fully visualized, entire squamocolumnar junction is visualized, patient compliant for a long-term follow-up, and both cytology and histology should correspond to each other. So these are some of the eligibility criteria. These 6 eligibility criteria should be met for selection of patients for performing ablative procedures. So ablative procedure includes cryotherapy, thermal ablation, and laser ablation. First one is cryotherapy. Crystallization. The mechanism in case of cryotherapy is crystallization of intracellular water of affected cervical cells followed by destruction of the abnormal cervical cells. This is performed with the help of nitrous oxide at minus 89 degrees centigrade and carbon dioxide at minus 65 degrees centigrade. So the cycle will be like freeze-thaw freeze cycle for 3 minutes, 5 minutes, and 3 minutes respectively. Aim of using minus 20 degree temperature at the end of frozen cervical tissue is to destroy the 5 millimeter depth of the cervical tissue. Choose the correct size probe which is covering the entire lesion. Remove the probe only when it falls off on its own from the cervix. This cryotherapy is not suitable for lesion extending for more than 2 quadrants or if extension to endocervical canal is present. This cryotherapy is not suitable for these cases like extending more than 2 quadrants or if extension into the endocervical canal is diagnosed. So this picture is showing a thermal ablator. This thermal ablator will have a removable probe with a heating tip at the end and a cool probe shaft will be there. There will be timer and status indicator lights will be there. Activation button, on off button will be there and low battery indicator will be there. So here electropottery will be used. 5 to 7 millimeter depth of the cervical tissue will be destroyed with the help of this thermal ablation. So this is battery operated. Then another one procedure is laser ablation. Laser ablation also utilizes carbon dioxide laser. With the help of the laser, 5 to 7 millimeter of the affected cervical tissue will be destroyed. So the main disadvantage of all this ablative procedure is there will not be any tissue for sending for histopathological examination. Tissue diagnosis, we can't able to get tissue for diagnosis of the lesion. And post-procedure period, patient will be having excessive vaginal discharge and patient will be having fever, pain, bleeding will be there. So these are some of the disadvantages of performing ablative procedures. Moving on to the excisional procedures, which includes LEAP, which is nothing but loop electrosurgical excisional procedure. In this, a thin wire will be placed on an insulated handle that will utilize electric current. Different sized loops will be available as shown in this picture. Specimen should be removed in a single pass or multiple passes if the lesion is large. So with the help of this LEAP excisional procedure, you can able to obtain tissue for histological examination. Another procedure is large loop excision of transformation zone, otherwise called as LITS, which is also similar to LEAP, except that the entire transformation zone is removed along with the lesion. The next procedure, third procedure is needle excision of transformation zone. Here, needle electrode will be used. That will excise entire transformation zone along with the lesion. Deeper and complete tissue specimen when compared with LEAP or LITS. This specimen will be obtained on a one-piece large specimen, and orientation of the specimen will be preserved in case of needle excision of transformation zone. But this takes longer time than LEAP. More bleeding will be there and difficult learning curve. Difficult to learn the procedure of this needle excision of transformation zone. Another one procedure is wholeness conization. The previous excisional procedures, like as we discussed about LEAP, LITS, NETS, those three procedures will require only local anesthesia. That is an advantage with those three procedures. But whole life conization will require general anesthesia or regional anesthesia. Here, cone-shaped biopsies, cone-shaped specimens will be removed containing transformation zone as well as abnormal CAN lesion. Keeping base of the cone at ectocervix and apex of the cone will be at the endocervical canal near the internal os. Using knife or even LEAP electrode can also be used for this conization procedure. Bleeding points after procedure will be cauterized and vaginal pack will be left for 24 hours. The main advantage of this whole life conization is it is both diagnostic as well as therapeutic. The most important thing is to choose the shape of the cervical conization based upon the configuration of the lesion. You have to choose the size of the conization. Complication of all these ablative procedures and excisional procedures are hemorrhage, infections, discomfort, cervical stenosis or cervical insufficiency, more commonly seen with conization. Both diagnostic as well as therapeutic conization will lead to development of cervical stenosis or cervical insufficiency. The most important thing after treating the patients of CAN with either ablative procedures or excisional procedure is the follow-up. Follow-up period is very much important. If margin of the cone is positive, you have to repeat conization or hysterectomy depending upon the family status of the patient. If the patient has already completed family, it is better to go in for hysterectomy. If the patient is desirous of pregnancy, it is better to go for conization. If invasive cancer is detected at any point in the follow-up period, you have to treat the cancer according to the stage of the cancer. If margins are negative, you have to follow up with cytology at 6 months, 12 months in the follow-up period. And if twice consecutive cytological reports comes as negative, you have to move on to routine pre-early screening when it is done alone cytology, or when HPV co-testing is combined with this cytological screening, it is every 5-yearly screening that has to be done. So follow-up is very important for prevention of pre-invasive lesions and invasive lesions of cervix. So this concludes CAN lesions. So prevention is always better than cure. Cervical cancer, even for prevention, awareness should be there. So for this awareness matters even before prevention. So thank you.